Welcome to the fourth webinar of our new series, Bringing Data to Life. My name is Eleanor and I work at the Office for National Statistics. We're delighted to see so many of you join us today for our beginners webinar on health statistics. Before we start, we'd like to remind you all that the webinars in this series will be recorded and will be available on YouTube after the event. The slides and recordings for our first three webinars, an introduction to statistics, environmental statistics and prices, are now available on the ONS website. Everyone signed up to this webinar will receive a link once today's recording is available. With so many of you joining this call today, the chat function is closed and all questions will be facilitated through Slido. I'll cover this in more detail in just a moment. This webinar series is for everyone, so please share the recording and slides when they're available and join the conversation on socials using the hashtag statistics for the public good. Lastly, you will be invited to complete a short survey at the end of the webinar, and we'd really welcome your feedback on the webinar series and the statistics we produce. So the webinar today is interactive and we'll be asking questions, so please join by scanning the QR code on your screen or heading over to slido.com and using the number 310-1575. If you're using the desktop Microsoft Teams app, you can click the Slido button at the top of your screen and Slido will appear on the side. The Slido code will appear on every slide, so don't worry if you miss it. So this is the final webinar for 2024, but we do have more exciting topics coming up in 2025. Our next webinar in January will be AI and data innovation, where we'll be explaining how ONS and NHS England are piloting AI. You can sign up to the next 4 webinars by going on to the Bringing Data to Life collection on Eventbrite or scanning the QR code on your screen now. I'm delighted to introduce our speakers today. We'll first hear from Amy Fears, an analyst in the health team at ONS. Amy will be sharing the stats we produce, how we collect life expectancies, calculate life expectancies, and how we will keep your data safe. We're also pleased to join by Rhys Powell from Public Health Wales. Rhys is a public health intelligence analyst and will be explaining what public health is and talk us through a diabetes case study. Once again, thank you everyone for joining, and I'll now hand over to Amy.
Hello, everyone. So as Eleanor just said, my name is Amy. I'm an analyst in the Health and International Directorate, so kind of in the health statistics team at the ONS, and I'm going to talk to you about some of the health statistics that we produce. So at the ONS, we produce a huge number of health statistics. You can see a lot of them on screen here. Just so you know, for coronavirus statistics, we can probably all really remember the time when we were producing those. We don't produce those so much now. But there's also a lot of different teams at the ONS producing these health-related statistics, and I just work in one of them. Now, the point in producing all these statistics that we have is to be able to track the health of the nation, both in the past and in the present, because quite a lot of the things that we do track things through time, which you'll see in some of the figures that I will show. Other government departments use the statistics that we produce to support and plan their own work. And we also, in different teams, and in my team particularly, we work with a lot of other government departments to provide analytical expertise for projects that they have. And I'll also mention that later on when I talk about one of our topics. But for now, I would like to please dive a little bit more deeply into life expectancies, which is the first thing I will talk about. So life expectancies is asking how long can we expect to live? So the ONS measures life expectancies and has done for a very long time. And something I want to show you in a moment is the life expectancy calculator, because it's quite fun and interactive and you can do this yourself at home. But before we get there, I'll just quickly explain that life expectancy is a measure of an average time that someone is expected to live. And it is based on quite a few different things, but one of those is also mortality rates. So the amount of people who die of a specific age. Now, there's 2 different methods which we use to calculate life expectancy. One of them makes projections and one of them does not. And for the life expectancy calculator, it takes the method that makes projections. And for some of the other life expectancy measures I'm going to show, it's the method that does not make projections. And that's why in a moment you are about to see some differences in what is calculated. But if we move on to using the life expectancy calculator, you can go here and type in your age and your sex, and it will tell you how long you'll live. So this is me. I'm 34 and I'm female. And when I type this in and calculate my life expectancy, it tells me that my life expectancy is 88 years. So it's the expected average age that I may live to. I have a 1 in 4 chance of living until I'm 96, and I have about a 1 in 10 chance of living until I am 100. And at the moment, this also shows you your state pension age in relation to your life expectancy. I don't know whether when I get near my state pension age, it might have changed. So we'll see that, but that's plotted on there at the moment. And you can play around with this a little bit, and you'll see that for different years, life expectancies are different, and they're different between the sexes as well. So if we move on from here, I have a question for you before I go on to talk about what we think average life expectancy is and what it is. And I'd like to ask, if people are happy to vote, please, what do you think the life expectancy is for males and females in England and Wales? So you have these 3 choices. So 79 for males and 83 for females, 72 for males and 80 for females, or 72 for males and 79 for females. And so I'm just looking, it's really fun for me watching these numbers change in real time. So we'll keep this going for a little bit so we can find out what people think. Just watching. Okay, and so if you said the top one, it was correct, yes. So the some of the most recent data for life expectancy in England and Wales at birth for males is 79 years and for females is 83 years. Now you'll see that this just says England and Wales. The ONS produces statistics for all 4 nations on certain things, but quite a lot of our statistics end up covering only England or potentially England and Wales, because Northern Ireland and Scotland do have their own national statistics institutes that produce a lot of their own statistics as well. So this is what we know is the life expectancy at birth for England and Wales. And you see this, so this says for females is 83 years, but you saw in the life expectancy calculator that for me, it was 88 years. And the reason that it's different is because, as I explained before, we have 2 different methods. One uses projections and one does not, and that can cause some differences. Now, we have also in the ONS, we track life expectancy through time. So what you can see here in this figure is that life expectancy was increasing from around 1980, which is the beginning of both of these charts, up to about 2011. Life expectancy was steadily increasing. Then it stayed stable for a while, and then you can see right at the end there's a tiny little drop off, and that is primarily caused by pandemic-related deaths based on the calculations of how life expectancy is calculated. The pandemic-related deaths had quite a big impact on those. So this is life expectancy as we see through time. But a different question, other than just how long might I live for, might be how long will I live in a state of good health? And that is called healthy life expectancy. So for some work that was published in March that was looking at life expectancy up to 2022, healthy state life expectancy, so how long could you live in good health from birth, was calculated for England, Northern Ireland and Wales. It was not calculated for Scotland because the Scottish census information wasn't available at the time. And you can see it's also broken up by regions. And what's particularly interesting about this that you can go away and have a look at is to look at your own region and see what's the healthy state life expectancy in your region. So in the left figure here, or the left on the very bottom left, you can see the northeast life expectancy, healthy state life expectancy, hovers at around 60 to 61 years for males and females. Whereas on the right hand white figure box in the middle, the southeast, it's hovering at around 66 years. So you can see that there are these regional differences. And hot off the press, just this morning, we had another publication about healthy state life expectancy. So that's partially updated some of these figures. So we now know, that was just published today, that in England, for males, the healthy life expectancy from birth is 61.5 years and females is 61.9. And in Wales, for males is 60.3 and for females is 59.6. But what's really interesting about this specific release and this work that the team have done is that they've been able to break up life expectancy by local authority. So we're going down to an even lower level of looking at life expectancy in areas. So I'd encourage people, if you're interested, to go away and have a look and see what it's like in your specific area, because you can, look at areas bordering on others and you can see some things here. One important thing I think to think about with healthy state life expectancy as well is that it's calculated based on information from life expectancy tables and also measures that we hold of good health. And that used to be measures that came out of surveys that ask about people's health status, but now this has slightly changed. So these statistics that are on screen right now are official statistics in development, because there has been a small change into what is the best way to actually measure the good health of the nation. And that's now being taken out of some other different types of surveys and information that the ONS holds. But that kind of sums up what we do about thinking about life expectancy. And what you've just seen is that we can really drill down to quite a low level, to the level of local authority, to provide these estimates of life expectancy. And we can do something quite similar with aspects of health inequalities. So health inequalities is looking at the differences in things to do with health relating to a lot of different socio-demographic factors. So one project which had looked at this, which is also an official statistic in development, and that means that it's something that we're still working on kind of in this area, looked at mortality rates for deaths for lots of different health conditions and broke that up by individual conditions as well. So if we first think about the health conditions on the right-hand side, you can see some of the areas that were covered were different kinds of cancers, cardiovascular diseases, chronic kidney disease, dementia, diabetes, respiratory diseases, and actually there's a whole host of other different health conditions. And these results were presented, broken down by different socio-demographic characteristics such as age, sex, ethnicity, an index of multiple deprivation, which is quite a complicated measure, but it's essentially a lot of different types of measurements that get combined to try and measure how deprived an area is. Socioeconomic classification, which is a measure which effectively takes different kinds of jobs and groups them into specific categories. Then region, and also down to a local authority level. And so I'm going to show you the kind of low-level information that we can look at when it comes to health inequalities. So if we look here on the left-hand side, what I have chosen to show you here is mortality rates for lung cancer. And so this is numbers of people who have died, but standardized over a course of lung cancer. I have selected this to show you by an index of multiple deprivation, with on that figure, the most deprived areas being at the top and the least deprived at the bottom. And the purple bars are for females, and that blue-green color, I'm not quite sure what color that is, blue-green color is for males. And so what you can see here is that mortality rates are highest in the most deprived areas and lowest in the least deprived areas. But for females, they are always lower than for males. Now, a very important point that I want to bring up here, which applies to most things that we do at the ONS, but specifically or definitely to this work, is that we are measuring things that we can observe in data already. This is just correlational. This is just looking at patterns. This does not tell us any kind of cause. So you cannot infer from this that living in a very deprived area is going to make your mortality rate higher. There's no cause that we can show. All we can say is that we observe higher rates in the most deprived areas compared to the least deprived areas. Now, if we turn to the figure on the right here as well, so we're looking now at dementia and Alzheimer's disease and mortality rates for those, and we've broken it up by region. So what you can see in this figure is that all the purple bars go out further than all of the bluey-green bars. So actually there's higher mortality rates for females than for males, and they also vary slightly by region. So the East Midlands at the top has a higher rates for males and females than, for instance, London at the bottom. And actually London at the bottom has roughly similar numbers for males and females in their terms of mortality rates. If we look at the next figure here on the left, we've now broken this up by ethnicity. So this is cause of death is diabetes, broken up by ethnicity. And so you can see that for people of Bangladeshi ethnicity, they have much higher rates than some other ethnicities, and they've ordered these in like highest to lowest rates as well. So you can see that there are variations in ethnicity. And again, there are some differences between males and females. And if we look on the right, this is how specific you can get with this data. This is looking at mortality rates for chronic obstructive pulmonary disease, or COPD. And I have broken this up by socioeconomic classification, which is someone's kind of job category. I will show you a bit more in a moment, and males and females, and also by age. So if you look at that figure at the bottom with all these tiny little boxes arranged into these slightly bigger boxes. So all of the purple bits are for females and all of the bluey green colour are for males. Now, across the top, you can see age categories. So the first column for each of those is people younger than 40, and then it goes up in by 10-year age bands, and the very highest is 80 plus. And so firstly, what you can see is that as people are getting older across females and males, there are higher mortality rates. And then on the left-hand side going down, you can see their job type. So for people who have never worked and are long-term unemployed, and then people in routine occupations and people in semi-routine occupations, so that's the top 3 rows, they have higher rates than people more towards the bottom of the job category description that's here, and those are lower and higher managerial, administrative and professional occupations. So what I want to show you with this work is that we can look at a whole host of very specific health conditions and a whole host of very specific breakdowns in terms of socio-demographic variables, and really try and understand and see where actually these health inequalities seem to lie. And this work in particular is of a lot of importance to, for instance, the Department for Work and Pensions, the Department for Health and Social Care, the NHS, and other different government departments that are really trying to focus on reducing inequalities in health, because if we don't know where the inequalities are, then we don't know what we could reduce. So this is something that's gone on with this work. And now I just want to shift slightly, but introduce you to a specific service that the ONS also have, which is called ONS Local, where you can explore local statistics. So again, in this vein of looking at things that are really drilled down to this local level, you can go here. This covers the whole of the UK, and we pull in data from some other areas, in some cases, and sometimes just from the ONS, but it's covering all 4 countries. And here we've looked at Edinburgh as an example on the left-hand side, and I've taken out health and well-being, but you might be able to see the contents links that are on there. You can also look at things to do with the economy and education, so it's not only health. But what you can see here, for instance, so the city of Edinburgh, the counts of, for instance, cigarette smokers is 9.6%, and that purple box that says 11.4% is the average of all other local authorities. So you can see where your specific local area falls in relation to things like how many people smoke cigarettes, what's our healthy life expectancy for males and females. I think the disease and preventable mortality is specific to Scotland. There will be other things that might be specific to certain areas in here, but I encourage people to go and have a look. And all of the things I've said, I encourage you to go and have a look. At the end of this talk, you will receive an email with all of these different links in, so you can get them there. Okay, so now I want to go on to my final area, and this is one that's more close to my heart because I'm an analyst in this area, where we link health data and economic data. So we're looking at this interplay between health and work. This is looking at the impact of health interventions on earnings and employment, and we have these de-identified data sets which have linked together data from hospitals, HMRC's, for instance, pay-as-you-earn system, the Department for Work and Pensions benefit system, and lots of other ONS data that we hold that are required for the specific research projects. And all of our data sets, as I've said, are de-identified, so they are anonymized. But I think this part brings up a lot of questions, and in a few slides I'm going to talk a lot about data security. So if you have questions about this, you might want to hold off until I've spoken about it, because it's a big thing to link together our health and economic data. But before I talk about that, I would like to ask you a question, so you can jump back into Slido. What do you think linking health and work data could show us? And this should create some kind of word cloud that might turn up on the screen. So we'll see how well this works. So, yes, these are all good. I actually work partly in a mental health related team. So I look at health and the economy, but aspects of mental health. So I like the mental health issues part there. So this is fantastic. So yes, we definitely find lots of different types of correlations, different trends where there are inequalities, different patterns that we can find. Obstacles to working is good. How work's good for you. This is great. So these are all fantastic ideas, and I think I can keep that word cloud and think back on it afterwards. But now I'm going to talk about 3 different releases that we've recently had. So this is a really new area, and our first release that came out of this was on bariatric surgery in October. And this looked at people who have had bariatric surgery and then looked at their employee pay in the months up to 5 years after surgery. So you can see in this top figure here that at the very beginning, all the blue bars that are going down shows that right after the surgery, they had a drop in pay, and then the monthly employee pay starts to raise as time goes on up to its 60 months as the very end of the y-axis on the bottom. So that's where it goes up to 5 years after surgery. Now the middle figure shows the effect of employee pay among people who were in paid employment when they had the surgery. So you can see from that that actually stays quite flat and there's not such a big difference. Whereas the bottom figure is the probability of going into paid employment through time after you've had the surgery, which really raises. So what this suggests is that having people who've had bariatric surgery are going into employment, and therefore the effect on employee pay may actually just be that more people are going back into the workplace after having the surgery. So that's one of the health and the labour market projects that we did. There have been two more that have both been released this week. So on Monday, we released a publication looking at the NHS Talking Therapy Service. This is a psychological therapy service that is in England. As I understand it, there is something very similar in Wales, but we don't have the data for that, and I'm actually not sure about the other countries. But this is, yes, the NHS Talk. So people who've used the NHS Talking Therapy Service in England. And so this blue, so on the left here, the blue bars are the change in monthly employee pay in years since your first therapy session for people who completed their treatment. So you can see that after they have the therapy, this raises. And the bottom shows you the probability of being a paid employee after you have completed your treatment. So quite similarly to bariatric surgery, we see that in the years that go on after you've completed your therapy, there is a higher rate of going back into work. On the right-hand side here, the endometriosis work package for this case, this is the first release in a series. This describes the characteristics of women with an endometriosis diagnosis. And in this work, the average age of being diagnosed was 35 years old. And in the data that the project was based on, because it's based on hospital diagnoses, the proportion of women in there who had been diagnosed with endometriosis was about 2%. But this is likely to be a huge underestimate because this is based on diagnosis in hospitals and not in the community setting, like with GPs or in other community-based care, because we don't have that data. This also showed some really interesting breakdowns, socio-demographic breakdowns, such that the rates of diagnosis are quite different depending on deprivation of the area that you're in and also based on ethnicity. So I definitely encourage people to go and have a look. And the work, the labour market that's attached to this part of the work is going to be released in the early 2025, so just at some point in the months after Christmas. And that's when we will hopefully then be looking at whether there have been any changes to employment or employee pay relating to endometriosis diagnosis. So that's where we're at. There are a lot of other projects on the go in this space, but that's what we have at the moment. And probably a question that many people have is about data security. So this is the last thing I want to mention. So we hold a lot of data, and actually linking health data related to economic data actually sounds quite scary, right? But the ONS has a very strong principle of data security and keeping personal data safe. And I am an analyst and I work with this data. So I wanted to talk through these 5 points from the perspective of someone who I sit there in these analysis platforms and I work on it. So firstly, the data itself has to be safe. So as a researcher, I can only use data that has been de-identified. So I can't find any identifying information about people in the data set. There's no names, there's no postcodes. Even in data I work with, we don't have dates of birth, this kind of information. And I can only access the data that I am required to in order to work on the project I work on. So it's also not the case that people can just access anything that they want to access that the ONS holds. In terms of having a safe setting, we can only analyze our data and see the data in our secure analysis platform. This is not just on our laptops. We have to go through a lot of different login loophole verification systems to be able to access it. And we can't get data out of it either. Well, we can get some outputs out of it, but we can't get the data out of it. I'll come on to that when I talk about outputs. We are also safe people. So we are trained and accredited, and we go through a lot of training, and we have to periodically update our training in order to use the data appropriately. Most people also in this space have also come from backgrounds where they've also had to go through ethical processes for data and data analysis, and everyone has to hold security clearance at a government level to be able to access this as well. The projects that we work on are only used for valuable, well, it says valuable and ethical projects. So firstly, the projects we work on have to go through very high level ethical approval procedure that goes up to the National Statisticians Ethical Procedure Group to have a look at. And part of the ONS's mission is to deliver statistics for the public good. So we only deliver statistics that should help the public and derive a benefit. And part of that means that none of our projects can be used for operational purposes. So we do not run projects that would say things like, you can or cannot have this health intervention, or you can or cannot, or you do or do not qualify for a certain benefit based on the work that we do. So we don't use, our data is never used for things like that. And the safe outputs is that our outputs are checked to ensure we cannot identify data subjects. So while everything is de-identified, there is a point at which, for instance, maybe someone could die of such a rare illness in a specific area that they're the only person in a specific year that died of that illness in that place, and that makes them identifiable. So we have a lot of procedures to go through to make sure that kind of thing doesn't come out as an output. And also, for instance, myself, when I have to check all of my work, and then I have to pass everything over to another analyst who is also trained to have to check all of my work again. Then it goes to another person before anything can be extracted from our system. We don't have the power to do that ourselves. And then it goes through lots and lots of internal processes to check the rigor of our statistics and also to check the safety of the data. So I wanted to talk this through because it's a very big focus at the ONS to keep personal data safe. And it may sound a bit silly, but us all at the ONS, our data is also in here too, right? I'm an employee. My salary information is in the data sets that I use. I don't know who I am, but I know it's in there. Like, I'm paid, so it must be in there. And so we take it very seriously, both at the ONS whole, but I think also individual analysts. It's data security is really paramount, and it's something that we really do care about. So, having finished on this topic, I would now like to hand over to Rhys, who is going to talk to us a little bit about public health. So thank you.
That's great. Thanks, Amy. Hi, everyone. My name is Rhys Powell. I'm an Advanced Public Health Intelligence Analyst in Public Health Wales, and I'm here today to talk to you about what exactly is public health, some of the official stats that my team are involved in producing, and to talk you through one of our ongoing projects to show how data can be used to inform action. So first up, what exactly is public health? This is my turn for a word cloud, so this could be interesting. So you tell me, what do you think we're referring to when we talk about public health? As a country, hospitals, prevention coming through. Yeah, so there's a few things here coming in that are definitely on the right track. It is about things like prevention, the health of the population, and like I can see a few lifestyles, different things like that coming through, and all of those are certainly on the right track. It is all that and a lot more. So what is it? So it is a lot more focused on the health and well-being of the public and how we improve it, rather than measuring how healthcare providers are doing. So it's focused on disease prevention and health promotion. It's about helping people live longer in better health and trying to reduce the health inequalities that Amy was talking about earlier. And it's not just about health conditions, it's also about wider determinants, things like your employment, housing, and the environment. All these things play an effect on an individual's health and well-being, so they all need to improve. So it's not about performance measures, and it's not about setting targets for healthcare providers. At the bottom there, that's the sort of Public Health Wales slogan, and it really sums it up well. Our aim is to have the people of Wales living longer, healthier lives, and trying to reduce that gap that does exist between people who are more deprived and people who are least deprived. Seeing as this is an ONS talk, I thought I better chuck in some official stats so they won't invite me back again. So this is just a few that my team are involved in the production of. So first up, we have the Congenital Anomaly Register. So this is a register that provides reliable data on congenital anomalies. So that's things like spina bifida, cleft palates, and congenital hearing loss. There's the Child Measurement Programme. So that's a programme that measures the height and weight of children in reception class each year. And last but not least, the Welsh Cancer Intelligence and Surveillance Unit, who produce the official statistics for yearly cancer, things like new cases, mortality, and survival. So quickly now onto the main part of my talk. So this is the evolution of a project, showing how health data can be used to inform action. So this actual project focuses on diabetes. So I want to very briefly give a bit of a background on diabetes. So there's two types. Type 1, which is a lifelong condition. Your immune system attacks and destroys cells that produce insulin, and there's limited lifestyle changes you can make to lower your risk of developing it. And then type 2, where your body doesn't produce enough insulin or doesn't react properly to it. And there are things you can do to reduce your risk of developing this, like healthy eating, regular exercise, and achieving a healthy body weight. 90% of cases of diabetes in the UK are type 2. So this project actually started off as something else, the Rapid Overview Dashboard. This was started in 2020 as a way to monitor some key health indicators during the COVID-19 pandemic. And one of those indicators focused on excess mortality due to various diseases. And it became clear that diabetes had seen fairly consistently higher levels of mortality when compared to the pre-COVID period. And so we had a request from our board to look at this in a bit more detail. So this chart is what started it all. The green line you can see shows the average for the 5 years before for a certain month of the year in terms of the historic data of how many deaths related to diabetes were there. And then those blue lines, that's the actual figure for the current year. And as you can see, it's kind of consistently higher, and that's kind of what grabbed the attention. So the board asked us to do a deep dive, and we put together a slide deck that looked at a whole range of indicators related to diabetes. And so that slide deck included information on disease prevalence, hospital admissions, prescribing trends, treatment costs, cost to the NHS, and then new for us, disease prevalence projections. And what did this data show? So most of the data already existed in some format, and it's only the projection shown here that was a brand new angle on the situation. One of the biggest changes was in how we presented it. So we brought all the information and key points to one place. We ensured the charts were easy to understand and crafted a very clear narrative throughout the slides. This repackaging, along with these new projections, allowed us to really help communicate the situation. So this projection chart shows a blue line, which is the registered patients. And then towards the end, you get a green and dotted lines, and that's where we project it could end up if nothing changes in between. Now, these are for registered patients, so you only show up in this data if you are registered with a GP and diagnosed. So if you're not registered with a GP or if you're undiagnosed, you're not going to be caught in the data. So this is potentially lower than the true prevalence of diabetes. And what was the impact of this work? So through our work, we were able to illustrate the number of people with diabetes, how much it could potentially increase to around 1 in 11 people. How the cost to the NHS has increased over time, both financially and in terms of resource. And that people with diabetes were having poorer health outcomes, and that we're showing no downward trend in terms of prevalence, health outcomes, and cost. And so the situation's only going to worsen. Through this, we're able to really emphasize that prevention truly is crucial in terms of diabetes, and that the system just cannot cope with an increase in secondary care. This message was able to connect with the decision makers and helped us launch the Tackling Diabetes Together program. So what is the program? So the program itself has sort of a few goals, two of the main ones being to have people living well with diabetes, so that's a reduction in things like amputations and other complications, and to stop the increasing prevalence of type 2 diabetes. So far, we've had engagement with Welsh Government ministers and key partners within the health and third sector. It's led to the creation of a communication toolkit for prevention and self-management. It's secured funding for posts to support the programme. It's secured funding to help deliver the work, and it's developed metrics to help us monitor if the changes we are making are working. Due to the nature of our work in health, we don't truly know the success of these actions for a long time. We have to wait and see, are we having a real effect? Are things taking a hold? Or is it just a little blip of improvement in the short term? However, from a project perspective, this was really successful for us. There's no shortage of worthy causes in health, but all that requires time and money to try and fix. So with this work, we were successful in engaging the people that needed to be engaged, showing them exactly what the problem is, what could happen, and where there are areas for potential improvement. All this helped to inform a plan of action based on the data we put forward, alongside expert input from colleagues across Public Health Wales. There is no shortage of data available in this world, and there's only going to be more as we go forward. And the ability to communicate that data effectively cannot be underestimated. So what's next for this work? So we're going to provide further support for any diabetes work, providing analyses where needed. We've already developed modelling work further, and it's helping to inform some diabetes services at a health board level. And it's actually been expanded into a series of articles looking at other disease areas like cardiovascular disease, respiratory disease, and then the risk factors that maybe make you more likely to develop one of these conditions. And this is just one example of one small project. We recently conducted an impact survey where we talked to our stakeholders and product users to see what they've done with our work. And we have a few more examples again of how our data is having an impact in the real world. Two of our dashboards, the Public Health Outcomes Framework and School Health Research Network, have been used in the Directors of Public Health annual report. The child measurement program that we spoke about earlier has really raised the kind of profile of obesity in children at reception age and getting the attention of ministers and getting them talking about it. Our primary care clusters work has helped GPs in Bridgend West with their spirometry projects, and the Welsh Cancer Intelligence Surveillance Unit's work on health board comparisons helped identify areas of good practice and where areas can be improved. So it is taking that data and making a real effect and not just doing data for the sake of doing data. That's it for me. Thanks for listening. I'll pass back to Eleanor.
Thanks so much, Amy and Reese. Really interesting presentations, and thank you so much to everyone for taking part in the Slido interactions. We're now going to move on to our question sections for the rest of our event, and we've had lots of great questions coming through on Slido, so thank you very much. We'll be answering the most popular questions first, so please do give a thumbs up to any questions you really want to hear answered. If we don't have time to get to your question today, the ONS Engagement Hub inbox is always open, so please do get in touch with us through engagement.hub@ons.gov.uk. So let's have a look at some of the questions that have come through. So the first one is, how do you define healthy life?
Okay, I will start by saying this is not my team, which I do not work in this specific area. It was up until not the release this morning, but the releases prior to this, the healthy life state. So actually, I'm going to interpret this question to say, how do we measure what a state of good health is? If I think that's what this means. So it was done based on something called the annual population survey, which the ONS runs, and they ask people like, what is your state of health? And there's also a lot of questions about, that they ask people about what your state of health is. And you take people who say they're in like good health, or is it great health, good health. There's a section that explains what is good health. And for people who answered yes versus no, and then we do a lot of estimating procedures alongside the life expectancy work to work out how many people are in this state of good health. As I understand it from the release this morning, one of the reasons this has now changed from an accredited, like an official statistic to an official statistic in development, is that there have been reductions in the number of people who have been taking part in the annual population survey. And it might be then that asking this question of people isn't producing the most representative response. And I think I would have to double check the release, but I think it's now that there is some information that's been taken out of the census that has been held, which also asks some questions about people's health. And the information is now being combined from there.
Lovely. Thank you, Amy.
But it does say in the release from this morning. I know it says.
Thank you.
Yes.
We'll go on to the next question. So how do you account for differences in characteristics like ethnicity, location, etc. in the life expectancy calculator?
I am very sorry, I cannot answer this question, but I can find out this question for you. If whoever wrote this can email it to the engagement hub, then I'll have your email address and I can find out and I can email you back with the answer, because I am not entirely sure. That's why.
Lovely, thanks, Amy.
Yeah.
Reese, I'm going to hand over to you now and give you a question, which is at the bottom. So for Reese and team's diabetes work, what test was used for the diabetes prediction/modelling?
Oh, I thought I dodged a bullet. So I mainly just ride on the coattails of my very talented colleagues, but we used an ARIMA model for this. Again, likewise, if you get in touch with the engagement hub, I can potentially get a few more details within that, but it's an ARIMA model where we've used a registered count of a population and we've taken that forward. That's sort of like the short version. But yeah, if you get in touch, I'll see if we can get you some more details.
Lovely, thank you. We've asked the second one, so I'll go to the next one. So with morbidity, sorry, increasing, how do you determine the cause of death when more than one condition are likely to be a contributory factor?
I think this would be a question for me. This is also something I cannot answer from the perspective of the ONS, because when we take cause of death for these things, we are using the cause of death that is listed on the death certificate. So this is something that whoever has written the death certificate for this person has listed. When we are talking about causes of death in the work I showed about health inequalities, it is about like the primary cause of death. So the death certificate has a specific, this is the main thing we're going to say cause death. And then there's a lot of other things that potentially contribute to the death, and they are all listed. So it is possible to look at, this is not what has been done, but it's theoretically possible to go away and look at health inequalities work based on some of these other conditions, based on other information that's been given on the death certificate. But we ourselves do not determine what a cause of death is. We take that information from a death certificate that's provided to us.
Lovely, thank you very much. I did see another question, which is for both of you, which I think is at the top. Yes, what are some of the challenges you face day-to-day work from a data perspective?
I'll go first, give me a break. I think for me, I guess it's partly about having high quality, consistent data. I think particularly in Wales, when we're reliant on sort of Welsh funded things, we haven't quite got the same bank account as the ONS and the census. So, you want that kind of same data, the same question asked for years and years and years, so that you can really get an idea of what's going on. The less data you have available, but the more of an estimate it is. I think that's probably one of the bigger issues, getting the right amount of data at a small enough, useful enough level. There's been a lot of questions around how low can we go. We want to go as low as possible, but sometimes they're just not collected at that, and it's frustrating for everyone involved. So I think, yeah, getting consistent, granular data is probably the biggest challenge.
Definitely. And Amy, how about you?
Even though we're at the ONS, and yes, it's true, we're a bigger institute and we hold a lot of data, to some extent we have exactly the same problems, like going as granular as you can while making sure that your data is good enough quality to answer the questions. We also suffer with things like missing data or incorrect data, and it's hard then on a day-to-day perspective to look at it and you're trying to really verify that what you think you've got in front of you is a good measurement of the thing you're looking for, and we don't want to ever release information that could be incorrect, right, because we haven't got good enough data. So yeah, I think the same kind of thing from this data perspective, and I think like Reese as well, I mean, we're working with sets that have millions and millions of entries in them. So it's really a case of being really, really sure that everything that you've got in there is the best it can possibly be.
Lovely, thank you very much. I think we've got time for a few more questions. So the next question is the methodology the same for life expectancy and healthy life expectancy? And is this what the government based retirement age on?
Partly. So there are two measures of life expectancy. As I said, one, it has projections, which I think is called cohort life expectancy, but I may have that wrong. But this has the projections in it. And the other one is period life expectancy, and that doesn't have these projections, and that's based on a specific year, and then people of different ages within that year and what their life expectancy is. The life expectancy calculator uses the one with projections. The life expectancy, where I showed you just the figures where we talked about 79 years for men and 83 for women, that is based on period life expectancy, and healthy life expectancy uses the same underlying tables as this period life expectancy of the 79, 83 years old. I will have to double check that is the one the government based retirement age on. It is written in one of the publications, which one it is, but I can double check and find out and get that information sent out in a link. But yes, so parts of life expectancy and healthy life expectancy are using quite similar underlying methodologies.
Lovely, thank you, Amy. And then final question is for Reese. Are there any plans to update the cancer reporting tool with more recent data?
That's not my team, but there are, I believe, I know we've got some more official stats coming out February, March time. But yeah, they recently moved to a really great cancer reporting tool. And I know we have got some schedules coming up, and I think we have recently put actually a better publication calendar on our website if you can locate it, and I think it's got a bit of a better idea of when their releases are. But again, if you go through the engagement tab, I can dig that information out and pass it on, but we have got dates for.
Lovely. Thank you, Amy and Reese. I think that's all we have time for today in today's session. So before we wrap up, we'd just like to share how you can get involved. So of course you can attend other events in this series, and we will be running one every month for the next year. So the next 3 events are now available on Eventbrite. The next 4 events are now available on Eventbrite. So please do go ahead and sign up to those. You can follow official statistics producers on social media, whether that's LinkedIn, Instagram, X, or other platforms. You can also respond to consultations and engagement questionnaires, which are opportunities for us to really understand what user needs are from our outputs. And lastly, if your household is selected for a survey, we'd really value your time and responses so that we can gather really meaningful data across the UK to better understand our society. Before you go, we would like to gather some data ourselves to find out how you found today's session. This can all be done on the Slido page that you used for today's session, where there'll be a quick survey. We'll also send the link to the survey once we have finished. But once again, thank you, Reese and Amy, for your presentations today, and thank you everyone for joining. Goodbye.